So hello, everyone. For those I haven't met, my name is Christine Haythorne, and I am the CEO of the Parkinson Foundation, Western Pennsylvania. I know you are missing your girl, Casey. Um, I am too. She's on vacation, and I don't like it when anybody else goes on vacation. um, I am so delighted to introduce Dr. Cardone, who has become such a dear friend of this organization. Um, I I've told her boss this. I'm not sure I've ever said it to her, but
Wow.
I feel like she is, in a very good way, a market disruptor in our region because she has a different approach to dealing with Parkinson's disease. And I think she's raising the bar for everyone to just be a little more engaged with their patients. So I'm delighted to have her here today. I ask that if you have any questions, put them in the chat, and um, Priya will answer them at the end of her presentation. I'm also really thrilled to say that her first presentation for our organization was what to expect in your first appointment. And at that time, we were unable to record the meetings. And I can't tell you how many phone calls our organization has received to have that program available. So we decided it's probably best to repeat that. So if you weren't on the first time, I can tell you that I did not like this topic when Priya suggested it. I thought, we don't have a lot of people who are that we know are newly diagnosed and are just starting this process. But this is what I mean by a market disruptor. I think she talked about her approach and it's changed everything. So for round two, I'm going to turn it over to Dr. Cardone. I'm going to mute everyone and she will unmute herself. Take it away.
Thank you so much, Christine. I really appreciate.
Oops.
Oops, there we go. Can you hear me now?
Absolutely.
Okay, thank you so much, Christine, for your introduction. I really appreciate hearing those words. Thank you also for hosting and coordinating all of this. It's very helpful to me and my patients to be able to send them these resources after the fact, after I see them. So welcome, everybody. So yes, my name is Priya Cardone. I am a DO, which means I'm an osteopathic physician, which means I was trained in such a way that we are supposed to treat the patient holistically, meaning a head to toe approach. And there's no disease I can really think of that needs this more than Parkinson's disease because it truly affects the head to toe of the patient's body. So it's a good thing to be very holistic about this. So my first topic is what to expect at your first visit. So we see patients for the very first time sometimes, and sometimes when they come, they've heard the word Parkinson's, they know that their doctor is sending them to a neurologist for evaluation for potential Parkinson's disease, or sometimes they don't. Sometimes the chief complaint is just written as tremor. This patient has a tremor. Can you see them? See what you think. So all of these are typical and common ways where we see patients. So it is good to know what to expect at your first visit. So this is something that patients can watch afterwards and kind of help them compartmentalize and piece together what was done at the visit, because sometimes it can be overwhelming. So why are you coming to see a movement disorder specialist? These are some of the reasons people come to us. A tremor, that's the most obvious one. Patients themselves will observe the tremor, or a loved one or family member will say, oh, my spouse has a tremor. Can you figure out what to do with this? But the other less obvious and less visible symptoms are stiffness, stooped posture. Sometimes people just have a hard time standing up straight, and their gait and their walking looks a little suspicious to another doctor or another provider. Bradykinesia. So bradykinesia is a fancy word that just means moving slowly. And that doesn't apply just to walking. It also applies to body language. So when a patient is seated in a visit, all of us have a normal amount of body language. You move your hands, you move your arms, your legs, you shift positions. That's like normal body language and body movement. So some of this can be reduced for patients with Parkinson's disease, and that can look suspicious in the beginning. So that could be a reason for a referral. Off balance. So off balance is a big one. Balance is a huge thing that is comprised of a lot of different aspects. So balance requires your brain to be functioning in a specific way to be able to coordinate the body. It requires the body to be physically strong. Muscle groups have to be symmetrically strong. It involves spinal cord needing to be healthy so that messages can go from brain to spinal cord. So tons of things can affect balance, and most likely my next lecture is going to be about gait and balance. So we'll pay attention for that at the next time. And then
Dr.
difficulty
Cardone,
walking. Yep.
do
Oh,
you
you
have
can.
slides with this?
Yes, I do. I'm sorry.
No worries. I will allow
Share
you. Hold on, let me name you co-host.
share screen. Oh.
And Karen, thank you for pointing that out. There you go.
Okay. Okay, share screen. Yeah, there we go. Okay, can you see my slides now?
Yes, we can. Thank you.
Okay, very good. So where was I? Yes. So difficulty walking. Like I said, we're going to do a whole lecture on walking and balance and gait next month. But this is a very common complaint. Walking and mobility, that is what makes the difference between being able to live independently in your own home or needing to live in either assisted living or a nursing home, or even needing somebody to come into your home to help to take care of you. But walking and mobility is like the most important thing we try to maintain with treatment. And falling, sometimes it's as simple as just like I just keep falling, I keep losing my balance. When I reach up for something, I tip over backwards, I just spontaneously lose balance. So another little detail with falls. So when you're a med student and you're asking people questions, you say, how have you fallen? They say yes, so you just write down yes. But when you're a resident, you say you've fallen. Okay, how many times have you fallen? How many times have you fallen in the last 6 months? And then when you're an attending physician, you take it to that one next level is, do you fall? How many times do you fall? What is the reason for falling? So do you fall because you get lightheaded and you get dizzy and you pass out? Do you fall because you trip over something that your feet couldn't feel or that your eyes did not see? Do you fall because you were suddenly turning and you lost your balance? Do you fall because your legs are actually weak and they give out and you crumble downwards? And then that even next step is, are you able to get yourself back up? So that's the complete question regarding falls. It's not just, are you falling? It's all the details about the falls, because those three differentiating factors determine how do you go about working up the falls. Okay, so what should you expect at your first visit? The first visit is very busy. It's a lot of talking and it's kind of overwhelming for the patients, which is part of the reason why I made this video. And also part of the reason why we see patients back in the office. Usually I try to see them back within 1 or 2 months after the first visit, because that's just kind of the most overwhelming visit to patients. And it's easy for us to ask you questions rather than you knowing what to tell us without being prompted. So what do we do at the first visit? Most important aspect of medicine is a history. You have to know the story. What happened? When did it start? What happened? How have things changed? What evaluations have you had? What have you tried so far? What is getting better? What is getting worse? What is the rate of progression? And sometimes the patient tells us this, but sometimes and very frequently we rely on family members, but also what has been documented in the chart, because the age group of people we see usually have other medical problems, and sometimes it gets a little confusing to try to remember every single thing. So what I've actually started to tell patients is you should bring a binder or a notebook to your first visit and jot down at least a couple of notes, because I always give you homework. So you should jot down notes, jot down your homework, and then when you go home and do your homework, you don't even have to remember. You just write it down in your little notebook and you bring that back and we can review it together, because 3 to 6 months between visits it's a long time. Even a couple months between visits is a long time to keep track of everything in your head. Okay, so after the history, then we do a very thorough physical exam, meaning we examine the body and do a complete neurological exam head to toe. So that includes looking at all of the aspects of the face, the cranial nerves, which control movements of the facial muscles in different parts of the face, swallowing, etc. We do a sensory exam, which means perception of vibration, perception of temperature, perception of light touch. Are you able to feel your arms and legs? So right away, if I can evaluate and figure out that a patient has difficulty feeling their legs, that will tell me that that patient has neuropathy or impaired sensation that will contribute to their difficulty with walking or everything else really that's going on. Then after the sensation exam, we do a strength exam. So you want to check arms and legs, see how strong they are. If there's obvious weakness there, you will know that that is likely a contributing factor to difficulty with walking or difficulty with mobility. After that, we check reflexes. So with a little reflex hammer, that's a way of finding out if there is something suspicious, potentially suspicious in a patient's spinal cord that could be affecting their walking and balance and movement. And then throughout all of this, you're also doing a cognitive exam without telling the patient or without announcing that you're doing a cognitive exam. So I usually just use my judgment. Like, is the patient able to tell me all the facts and details by themselves? That signifies that they're cognitively intact. Does their family member need to fill in more than half of the details or about half or more than half of the details? That gives me a clue there may be some cognitive impairment. Is the patient and family member not able to tell me anything and I have to do all of the history by looking through the chart and reading through notes and kind of doing a lot of questioning myself? So that tells me there's likely a severe level of cognitive impairment. So you kind of use that to judge and figure out quickly how do you need to approach the cognitive aspect of whatever may be going on. All right, so after we do the history and the physical exam, for very straightforward patients, it can be easy to just make a diagnosis based solely on history and physical exam. So, 50 years ago, there were no pictures, there was no CAT scans, there was no MRIs. You had to use your brain to think and make a decision. Luckily, now we have a lot of tests to help us. However, there is no one test that shows if a patient has Parkinson's disease or not. It is still a clinical diagnosis, meaning it is based on the combination of the story you figure out as well as the physical exam findings. However, we live in the day and age where we have other stuff and patients are more and more complicated. So we do have to utilize other mechanisms to determine if there are any other underlying neurological issues or structural diseases or entities that we need to be aware of. So I always order an MRI as long as the patient is able to tolerate it and does not have any metal implant in their body that prohibits them from being able to get an MRI. So the MRI of your brain is the clearest, most detailed picture that we are able to get for looking at how a person's brain health is currently. So the brain MRI, a common question I get is, did you see Parkinson's on my MRI? The answer is no. There is no MRI finding that tells us if a person has Parkinson's disease. What I am looking for and what I'm shopping for is any other thing that could be contributing to the overall clinical picture or masquerading as Parkinson's disease. So there may be certain areas of stroke or certain areas of injury that can cause a patient to look like they have the symptoms of Parkinson's disease. And we have to take that into consideration when we're coming up with the diagnosis. The other standard blood tests I get for all of my patients at least once per year, there's 5. So vitamin D, which now has officially been linked to cognitive function and cognitive impairment. We also live in Pittsburgh and there's no sun here. So most of us have vitamin D deficiency, unfortunately. So I check that at least once a year. Ferritin and iron. These are a newish thing. So if you get your iron levels checked, it will come up as a flag if it's above or if it's below a certain number. Nowadays, there is a push by hematologists or blood specialists to raise what is considered to be the normal level. So previously the normal level, it's around 8 to 10 or 12, but now it's shifting upwards. So I've seen in the notes by hematology that there is a push to treat certain iron levels, which is the ferritin, which is the storage form of iron, if it's less than 50. So that's kind of a big difference. So again, things in medicine change. So that's why I check those, because iron deficiency tends to make all neurological conditions seem worse. It can cause fatigue, shortness of breath, cognitive brain fog, a little bit of twitchiness. So a lot of stuff can come of this. So I check for that. B12. So B12 is known to be absolutely necessary for brain health and neuron function. So I always check for that. If it's less than 400, I treat it depending on the patient's ability to swallow, a patient's ability to absorb the medication. So whatever your other issues, I will tell you what I recommend doing to treat that. And then I will recheck it later to make sure my treatment has worked. Thyroid. So when the thyroid is off, with whether you have hypo or hyperthyroidism, it can affect the neurological symptoms that you are having from a specific disease. So we check that and make sure it is in normal. And if not, we advise a patient to either check in with their primary care doctor or their endocrinologist if they have one. And I think I covered it. Vitamin D, vitamin B12, thyroid, and 2 iron studies. So those are the 5 things I check for everybody once per year. The next one is a nerve test. So again, if I've discovered on my physical exam that a patient has a lot of numbness in their legs and they're not able to feel different things that I'm testing, sometimes I get a nerve test to determine if they truly have neuropathy, and if so, what is the extent of that, or if they have nerve injury coming from their lower back, or if they have neither of those two, and it's a third category called small fiber neuropathy. But basically what I want to know is, where is the injury and how does that factor into the patient's ability to walk? Okay, so sometimes in the very first visit, like I said, if we were able to make a straightforward diagnosis and there's not too much extra stuff that we need to look for, we sometimes start treatment right away, because the treatment is both therapeutic and diagnostic. Because if you start the treatment for Parkinson's disease symptoms and you get better, great, that goes into my bucket of feeling more confident that this is in the Parkinson's disease category. So we can do treatment while we are waiting for results of other stuff. So it all depends on how complicated your clinical picture is, your ability to, what I perceive or what you tell me is your ability to try medications and document or keep track of the results, and then contact me later, or contact me either in between that and the next visit, or just kind of talk about it at the next visit and tell us what the response was. Okay, so the cranial nerve exam. Sorry, I guess I already did this. So the neurological physical exam. So the neurological exam is 5 things, but I really should have put 6 on here, which is the cognitive aspect. So cranial nerves, those are just head up. Anything in the head up that's abnormal pretty much localizes back to a nerve that comes out of the brain itself, as opposed to nerves that come out from the spinal cord. So then we check those. We check your sensation, vibration, pinprick, light touch, balance, proprioception, a couple of things there. Strength, we're looking for actual weakness. Reflexes, we're using the little hammer to check basically your spinal cord and your spinal cord's ability to regulate reflexes. Gait, so if I had to choose one thing to test, it would be gait. Gait is the most important, because gait is the difference between being able to live at home independently or needing to live in a nursing home. If you can walk, you can live in your house. If you cannot walk, you cannot even get yourself up from the wheelchair, then we need to have a serious discussion about where do you live and is it safe to live there. But that's the most important of everything. And gait is a combination of all of these things. Okay. So again, some of these things change, and I'm thinking of it as I'm giving this lecture. So cognition is one of the aspects. So gait is comprised of your brain being able to generate messages to send to your body to tell your body how to move different body parts and propel yourself forward. The brain sends messages down the spinal cord. So the spinal cord has to be healthy, normal. It cannot be getting pushed on by bulging discs. It cannot have areas of basically strokes, which is like impaired blood flow to the spinal cord that caused a permanent injury. Spinal cord sends messages out through little nerves to the muscles. So muscles have to be healthy, normal, functioning, and able to receive messages. The muscles have to sense the messages, but sensation also means the body needs to be able to sense where its different body parts are. So that's called proprioception. So even if you close your eyes, your brain should know where are your arms and where are your legs and what position your body is in. So that is a matter of sensation. And then other. So other is the cognitive, basically. So cognitive aspect of walking, thinking that you want to get up out of a chair. Your brain tells you to get up out of a chair. Your brain tells you to walk. You can think and perceive what are your surroundings. You can think and perceive if you have to go up or down, or if there's a piece of furniture in your way. That's this huge other category. Okay, so then what next? We've done the history, we've done the physical exam, and there's two categories. The diagnosis is very obvious, in which case we can just start treatment. The diagnosis is unclear, so then we do more testing. Sometimes there's a part where we also choose to do a medication trial, because sometimes the medicine itself can tell us the answer. So if a patient takes medication and they respond one obvious way, that can help tell us, is it actually in the Parkinson's disease category, or does it not respond to Parkinson's disease medication? Is it in a different category and we need to reevaluate? Sometimes we do watchful waiting. So sometimes patient symptoms are not very, very obvious, or they're looking like a couple different things mixed together. If the patient is really not terribly bothered by symptoms, it is not affecting safety and not affecting quality of life, sometimes we just do watchful waiting, which means please come back in 6 months. At that time, I will reevaluate, compare what you look like in 6 months to what I've documented you looked like at the first visit. And if anything obvious presents itself, then we will be able to know. Finally, there's a specialized brain scan called a DAT scan, which is a dopamine uptake transporter scan. So what this does basically is it looks at the function of dopamine neurons in the brain. It involves getting a special dye. Number one, there's a dye that goes in that protects your thyroid. Number two, there's another radioactive tracer that goes in intravenously. You kind of sit in that office for about an hour, wait for that dye to go up to the brain, percolate, and then you get a CAT scan. So this tells us just one thing: function of dopamine neurons, normal, abnormal. There's nothing about function. There's nothing about like percentages. It's just normal, abnormal. So this scan, there's a caveat to the scan. It sounds like you're probably thinking, oh, why doesn't everybody just get a DAT scan and then they know if they have Parkinson's disease and you just treat it and move on? So it's not that simple, unfortunately. There are a lot of caveats to the DAT scan. One of the caveats is other medications can influence the uptake of dopamine in those cells. So if you are somebody for whom a DAT scan has been ordered, you will get a phone call sometime before the scan to tell you a huge list of medications, to see what medications you're on and which ones need to be stopped and how long they need to be stopped for prior to getting the scan, so they do not affect the validity of the scan. Number two, if your brain has a lot of wear and tear on it, you've had strokes, you've had bleeding type of strokes, you've had a lot of brain injury. If you've had injury of the area that the dopamine neurons are, the scan may not be accurate. The scan may not be accurate if you are too early in your disease process and enough of the dopamine neurons have not actually been affected, that then you will potentially have a false normal scan. And so, yeah, basically a lot of caveats to this one and a couple of other things. Again, depends where you get it done. What is the quality of the scan? What's the quality of like the pictures that are taken? Do you have good enough blood flow that enough of that tracer really did even get into your brain? Who is the radiologist that reads it, et cetera, et cetera, et cetera. So that's like a huge asterisk with the DAT scan. I try to avoid using it as much as possible, except for cases where patients have at some point in their life taken medication that can cause them to look like they have Parkinson's disease. And you are unable to clinically differentiate those two. You will never be able to tell as a doctor, does a patient look, if they've taken antipsychotic medications in their life, you'll never really be able to tell clinically, is that true Parkinson's disease or is it effective medication? So that would be one time in which you can use that. Another time is if somebody has essential tremor for a very, very long time. Sometimes it sort of can look like how Parkinson's disease tremor looks. And if you're not sure, a DAT scan may be helpful in that situation. Okay, so what are the tests that we get? So I talked about it a little bit briefly, but we'll go into more detail. So number one, I will always like to know the general health of the brain, not only for the Parkinson's disease symptoms the patient may have, but for any other symptoms they're having, gait abnormalities, cognitive impairment, question of seizure activity. So we like to see how does the brain look. Sometimes I also get an MR angiogram, which is a picture of the blood vessels of the head. Sometimes I get the neck too, depending on what is the clinical story, but I like to see are all the blood vessels nice and open, and is the brain getting adequate blood supply? I'm here also looking for generalized shrinkage of the brain. I'm looking for generalized wear and tear on the brain. And if you have questions about either of those, I have another YouTube video called Cognition, which I can ask Christine at some point to put like a link or something in the chat. And that goes through a lot of age-related wear and tear on the brain and how do you accumulate that and what is the cause of that and what can be done to reduce progression of that. So next, we potentially order pictures of the spinal cord. So again, depending on the rest of the physical exam, if there's weakness or abnormal reflexes, we use that to tell us where there may be a problem in the spinal cord, and we use that to decide which portions of the spinal cord require pictures to be taken. Next, if there is an issue regarding muscle weakness or sensation, and we suspect that a patient may either have neuropathy or myopathy, which means actual muscle disease, like way out in the edges of the body, the muscle itself has a problem, we would evaluate for that with a nerve test called an EMG nerve conduction study. So that is basically a test where you get little shocks and it measures how fast and how efficient messages travel from the top of the nerve out to the edge of the nerve. Little needles are also used to measure muscles as they are getting stimulated, as the nerve supply to them is getting stimulated to make the muscle actually contract. And then we measure the contraction and see if it's normal or abnormal, and that can tell us if there's some other issue going on. Finally, if I detect on the physical exam that there is a component of neuropathy, which means abnormal sensation, we add a couple of extra blood tests into that category as well. Okay, so we talked about metabolic abnormalities contributing to worsening of all neurological symptoms. It's thyroid, iron studies, B12, vitamin D to an extent. That's more in the cognitive realm, more in the neuromuscular realm, but we add that on too. Other tests sometimes, if we think that there is an issue with blood supply to the arms and legs, like a patient has, for example, a history of smoking, and they say that their legs are cold all the time and they're walking and then their legs get crampy and numb and weak, then that raises our red flag. Is this actually something to do with reduced blood supply to the legs? So then we order an ultrasound to check for that. Okay, so then what do we do after that? So then the next step is basically the information gathering stage. So Parkinson's is a full body disease, meaning it needs a full body approach. So if you're working on a puzzle, for example, you kind of, most people will get the four corners, they get the border, they create the outline of the puzzle, and then you start filling in all the details. But that is a very, very crucial spot. You cannot treat an entire patient until you know what are all the ingredients that are contributing to their clinical symptoms. So you cannot ignore gigantic things. So if they have metabolic abnormalities, that's an ingredient. If they have gait abnormalities, that's an ingredient. If they have cognitive impairment, that's an ingredient. If they have untreated out of control depression and anxiety, that's an ingredient. So you have to like check off all the ingredients so that you know what is what, because each ingredient can affect the other ingredients, and all of them will contribute to the overall clinical picture. So after we've gathered information, we've identified all of the ingredients, then you start to choose different ingredients one at a time and start treating basically. So sometimes if I'm not sure, I ask the patient, what is the most bothersome symptom to you today that I can try to help with? And we can go from there. Sometimes, and very frequently, I also find that anxiety and depression kind of make everything look worse than they really are. So if I see a patient and I'm not clear on a diagnosis, or I'm leaning towards one thing, but there's so much anxiety that it's hard for me to even see past that. One of the things I do is like I'll treat that depression and anxiety first, kind of remove that from the clinical picture, and then whatever's left over is a little bit more neurological, and then it's easier to identify things that can be treated, and you go stepwise like in a progression there. So treatment options, medication, and then medication is one thing, but there's a whole lot of other comprehensive things that need to be done. So physical, speech, and occupational therapy are like all of those. Those are my favorite. Everybody gets better with a little physical therapy. So one of the things, like one of the analogies I use for patients is your body is kind of like a car. If you have Parkinson's disease and you don't have enough fuel in the tank, which is dopamine, and you can't really run your car that good. So what you have to do is you got to put fuel in, which is gas, but you also have to run the car. So you can't just like put fuel in and then let it sit in the garage. It doesn't work like that. So you got to put the fuel in, you got to put the oil in, but you also have to take it out and run the motor a little bit, and you got to use the body. So that's where physical, speech, and occupational therapy come in. You've put some fuel into that patient, and then they need to go out and have motor retraining of the body. So the body sort of forgets sometimes. It's like if it hasn't been moving accurately, if it hasn't been moving a lot, it sort of forgets what to do, and you need to get back into the rhythm of movements. Sometimes we also do, like I said, the watchful waiting. A patient comes in, sort of vague, nothing really obvious, or nothing really, really that bothersome. It's okay to wait. You don't lose any ground by just waiting sometimes. So 6 months period, you can wait, reevaluate. Sometimes the answer is more obvious at that next visit. So patients sometimes worry, well, what if I'm missing something? What if I'm losing ground? We're not. So unfortunately, there is no medication that stops, slows, or reverses the progression of Parkinson's disease. So we're not really losing much by waiting unless you're at the point where you have difficulty moving the body and you don't have enough fuel in the tank to practice moving your body. That's where we lose ground, in the sense that your body will then decline. And even if we kind of medicate you later, it will be to try to move a body that has already declined a little bit. It'll be a little bit harder to bring that body back up to its previously functioning level. Okay, so patient homework. So this is a two-way street. I'm the doctor, but I also depend on the patient to do some things so that we can move forward and have increased patient outcomes and satisfaction and treatment response. So your homework is always to obtain the testing that was ordered at the visit. Your homework is also to trial any medications that we've talked about or given you. So it means try taking it, but also you have to keep track, what does it actually do? And that depends on me telling you what to look for. So my pet peeve is when patients get medications and they're like, take this med, come back in 6 months. And the patient's like, it didn't work. But what does that mean? Like, were you educated on what it was supposed to do? So you should have been educated. So when I give patients a tablet, for example, Cinemet, I say, please take this, half a tablet 3 times a day for about a week, then 1 tablet 3 times a day. Your homework is to observe after each dose, what does the medication do? And I give you specifics. Does it make you get up out of a chair faster? Does it make you walk a little bit faster? Does your tremor go down? Do you feel a little stronger? Does your anxiety level reduce? Do you have an easier time catching your breath? Are you faster? So those are very specific things to observe for. So you can keep those in your head or you can write them down. Other homework is to observe for side effects. So that's, again, something that the clinician is responsible for telling you. Side effect is upset stomach. If you have upset stomach, you are going to drink some ginger ale, you are going to eat some crackers. If you do not pass through that phase, you have to call me. I can't do anything to help someone if they don't call. So again, always reach back out to your clinician if something doesn't feel right, because you can try something different rather than waiting all the way until the next appointment and then you're starting again from scratch. So I always encourage patients to call or send me a message with what happens so that I can adjust medications and adjust treatment in between visits, because then we've done a couple of things by the time I've seen you next, and then we can already have that under our belt rather than just doing one thing at every visit and then waiting until the next visit. Okay, then reevaluate. So reevaluate means come back after you've tried stuff or come back after you've gathered information, because sometimes the effect is not as obvious to the patient because you're home, you're doing stuff, there's a lot of stuff going on. Sometimes it's very obvious to me when you come back, like, because I also document how easy was it for this patient to get up off of a chair? Did they use their hands to get up? Did they get up without their hands? Did we have to pull them up to standing? And then I look at what you look like today and I read what I wrote last time. So then it's very easy for us to know, because sometimes if you're at home and it's like a slow process, it kind of can be difficult. So then we come back. I love to see my patients. I would love to see everyone every 3 months. Unfortunately, that's not always exactly possible, but I'm very lucky to work in an office where I have a couple of other folks helping me. So sometimes when I see patients and you have a lot of stuff going on, I say, let's try this. Can you come back in a month and see somebody else? And that is because it's easier for us to see what happened than it is to try to rely on the patient to keep track of too many things. So a lot of stuff in the beginning, it's nice to have someone to come back in and check in with, make sure nothing has like fallen through the cracks, orders haven't been lost, orders haven't been like done incorrectly. Like, you know, it all just depends. Like if you go to the lab and they don't have your blood work and you forgot to tell us, or they didn't tell us, you know, a lot of stuff happens. And that's the purpose of having a kind of frequent visits, especially in the beginning. Then the other homework is to see other specialists depending on the results of testing. So my pretty strict like standard, if you have low iron, you see a hematologist to determine why do you have low iron, and then to determine treatment options. If you have really, really bad neuropathy, like out of proportion to just regular garden variety neuropathy, and something else looks funny, sometimes I ask one of my colleagues to check in on you as a neuromuscular specialist or a neuropathy specialist. If you have, I randomly discover like really bad, poorly controlled diabetes, and it's out of the scope of just what you're able to do with your primary care doctor, it may be time for an endocrinologist, so I put that in. If I find that a patient has really bad arthritis in their neck or their lower back, and it's pushing on their spinal cord or it's affecting spinal cord or nerves, I usually send people to a neurosurgeon. So that all of these things, basically whatever I find, if it's not exactly in my category, I make sure you see the person for in whose category it is, to make sure it is evaluated and treated accordingly. So it's not interfering with our true Parkinsonian symptoms, solely Parkinsonian symptoms. Okay, then the other part of this is also establishing reasonable patient expectations. So if you come to me and like your disease process has been going on for a very, very long time, it may take some time to find a diagnosis and determine a treatment option. And we have to just be realistic. So it depends what else is going on and what else is contributing to the clinical picture, and what all things are truly neurological issues versus other body part issues. So we hope and look for a possible improvement of symptoms with the treatments that we offer. And if not, if we keep treating you like you have Parkinson's and we're doing all the Parkinson's stuff and you're just not getting better, then we do have to circle back and reevaluate, is this really Parkinson's or is it something else? Because there are a lot of other things that can sometimes look like Parkinson's disease. And Parkinson's, unfortunately, it's there for life. But it's not really that unfortunate. I mean, that's kind of how the body is. Any disease the body really has, everything you kind of get it for life. It's just a matter of how quickly does it progress, how bothersome does it affect your day-to-day life, and what are the treatment options, and how frequently and quickly does it change. So this will change. So this is something that we see each other forever, basically, and we have ongoing treatment adjustment for the rest of your life, because symptoms will always change, progress. Sometimes they worsen, some things get better. So you always have to be kind of try to stay one step ahead of it and try to adjust pretty much every time. So pretty much all of my patients, I'll say every time I see a patient, I adjust something or other. There's hardly ever a time where I just keep the same thing, because this is a progressive condition. So between visits, it's highly likely that something has changed, warranting a change of medication or change of treatment. Okay, so we can go through questions. Okay. Sorry, it's my patients mostly. Okay, if someone has a severe reaction to carbidopa, levodopa, or is allergic, what else can be done? That's a great question, because I actually just had this issue last week. So here's my handwritten list. I'll show you guys. Can you read that?
No.
No, okay. Um, it's okay. You don't have to read it. I'll put it in another lecture. But this is the list of Parkinson's disease medication from when I left fellowship. So it's a 3-year-old list. There's a bunch of stuff that I have to add to that. It's in my head, so I guess I never wrote it down. But if you cannot tolerate carbidopa levodopa due to side effect of nausea, the option is you switch to an extended release format, which has a lower peak dose in the blood, which causes less side effect. If that is not tolerable, then you add an extra dose of carbidopa only, which is like, if you have your medication, it's carbidopa levodopa. The carbidopa part is the part that helps the medicine go into your brain and away from like the gut, which is where your nausea comes from. So you can add extra carbidopa by itself. If that doesn't work, then you switch to another dose of, you can try a dissolvable tablet. Sometimes that bypasses the gut and you can have less of the nausea. Or you use a patch that goes, puts dopamine kind of basically straight into the skin. If that doesn't work, then we have a new thing called Vyalev, which is a dopamine infusion pump that goes right into the skin, a subcutaneous infusion, kind of like an insulin pump that can bypass or circumvent some of the potential side effects that a patient may have. If that doesn't work, then we have another more invasive treatment, which is Duopa, which is basically a peg tube that goes directly into the intestines, and that puts dopamine gel directly into the intestines, and that can bypass the side effects. If that doesn't work, then we go for the DBS. DBS can take the place of medications in certain situations, and that can bypass that. If none of that works, the other option is going straight for a medication that pretends to be dopamine, but is not dopamine. It just goes and sits on the dopamine receptors. So these are dopamine agonists called ropinirole or Requip or pramipexole, if you've heard any of those. So that's my list. That's what I do if we cannot tolerate dopamine sometimes, or if you cannot tolerate carbidopa levodopa, you have to be a little creative sometimes.
The situation that I just heard about, Dr. Cardone, was terrible diarrhea. It wasn't nausea, it was really bad diarrhea.
And they're definitely sure it was the carbidopa levodopa, meaning the medicine was stopped, diarrhea resolved. You tried the medicine again, you got the diarrhea again.
And they went through traditional carbidopa levodopa, and then they tried Rytari,
Mm-hmm.
and same thing, it kept happening.
Yeah, I would basically go down the list. So there's the dissolvable tablet. You can try that. It goes under the, you can put it under the tongue. It skips the stomach, skips the GI system. You can go for that subcutaneous infusion pump. You can go for the Duopa. You can go for the TBS. That's what I would try, I guess,
Thank
for
you.
that. Yeah. Okay, and then does the DAT scan impair one's ability to receive radiation down the road? Nope, it's just a scan. That stuff gets out of your system, and it's just like a regular CAT scan. Okay, and then have you had experience with Vyalev? Yeah, so I actually had my first patient this past week. So right now, unfortunately, the Vyalev, you can only be used on a patient who's less than 63 years old because they don't have like Medicare clearance or something like that, or they don't have Medicare approval or something. So you have to be less than 63. And something, it's like some insurance kind of limitations. So less than 63, I have a little post-it note here. I'm reading. It says less than 63 and Advantage plans. So it means commercial insurance, whatever that means. I don't know. My front desk office handles all insurance questions.
I think, if I may just interject, I think
Yeah.
that AbbVie is hoping to have Medicare approved insurance August, September-ish.
That's what I heard. Yeah. So
Yeah.
kind of just waiting, I guess. But yes, it's a good treatment option for patients who are having a lot of fluctuations because of reduced gut motility, reduced oral GI absorption, and they're just going up and down and up and down. And it kind of takes that away because it just goes right into the skin, right under the skin, and it's the same all day long with the ability to give yourself extra boosts, and then you get like loading dose in the morning, you get a base rate with the ability to do some extra dosages during the day, and it also covers you all night at a lower dose, so you're getting dopamine 24/7 basically. So I like it for whatever scenario that fits. If that patient needs that, that can be very useful and helpful. So it's one more thing that we have.
Any other questions for Dr. Cardone? Oh, here's some coming in.
Okay, I get a terrible taste in my mouth that's hard to tolerate. My husband, the diarrhea. Okay, no,
Those are two different people.
okay,
Yeah.
gotcha. The taste in your mouth, is that from when you take it by mouth and you swallow it to your stomach, or you have the dissolvable tablet?
You can unmute Walter if you want to just ask directly. Hold on, you're still muted.
Okay, I'll just say what I think.
There you go. Now you're unmuted.
Sorry.
Got it. My husband, he's had this now since he's had his Parkinson's, that he gets this very foul taste in his mouth. It's constant. It's like he's actually lost weight because of it, because nothing tastes good to him. And I didn't know if this was contributed to it or what, part of the Parkinson's.
So number one, is that like in relation to medication, or that's just all the time, no matter what?
All the time.
Food.
Okay, so number one, I would ask, first of all, is it acid reflux? Because that doesn't sound like Parkinson's, but a lot of people have acid reflux, and it causes a foul taste in their mouth, and it causes them to lose weight because their acid reflux is inhibiting the absorption of nutrients. So number one, I would ask that. Number two, I would say, is there a dry mouth issue? Because it's also just a common thing that people have. Dry mouth could be side effect of other medications, and that can be impairing the ability to taste normally. Number three, some other medications have a common side effect of metallic taste in the mouth, specifically acetazolamide, like that's a diuretic, but there's other ones that have that. So I would research those three things first before saying that it's the Parkinson's.
Yeah. Okay.
Yeah. I would ask your PCP if there's an acid reflux issue, and if you can try a course of acid reflux medications for a couple of weeks and see if that gets better, because that's a very common way of people presenting with a silent acid reflux. It's just this like soury bad taste in their mouth all the time.
Oh, and we did have one more question. We've had all the tests done for neuropathy, and they said he has a mild case of it, but his bottom of his feet are so bad. He said he feels like he's walking on rocks.
My feet, they burn constantly.
Yeah. So yes, so a couple of caveats about the nerve test. It depends on who did it. Regarding accuracy, it depends on who it was done by. Number two, it only picks up one type of neuropathy, which is large nerve fiber neuropathy. You may also have small fiber neuropathy that is not picked up on that, and that could be contributing to worsening perception of symptoms out of proportion to what the nerve test says that you have. So that's that. Number three, yes, if you have that much of discomfort, that would be something that can be treated in terms of nerve pain and nerve discomfort reducing medications. So I would ask your neurologist about that.
Okay. Thank you.
Unless it's me, in which case, please send me a message. But I don't think you're my patient.
No. We're just joining the group chat.
Okay, yeah, you don't look familiar.
It's enlightening. I like it. Yeah.
Good.
Becky has her hand up.
Okay. Oh, do I unmute her?
I think she has to unmute herself. I'll ask you to unmute, Vicky.
There we go. Yeah, this is Vicki and Donna. I just had a question because I just watched a PMD Alliance seminar from Jimmy Chu on how he takes his cinnamon. And he's determined a schedule where he controls based on his activity, he takes a certain amount of cinnamon. And I've been told by other people that you should follow a set schedule from your doctor.
Yeah.
But I was just wondering, do you promote the other way too, or?
Yeah. So I have two kids. I'm not a micromanager. So if you're my patient, you'll know that real quick. Like I do not micromanage that.
Came on.
Generally, yeah, and that both of those things are correct. So if a patient doesn't know and they have the same schedule all day long, I'm but I do tell patients like you are free at liberty to take up to two, usually I'll say up to 2 extra tablets a day as needed. So yes, if you're going to go to a high intensity workup and you know you need a little more juice for that, by all means you can take another tablet, and I'm fine with that as long as I have a general idea that they are what they're doing and it's not like more than like about 2 a day usually.
Because Vicky's experiencing severe offs like all of a sudden, like within 30 seconds. And I think it may be when she's coming down, but it just happens so quickly.
Yeah, so that would be something to ask your doctor about. Does the dose prior to those freezing episodes need to be increased, and or do you need a rescue medication or something else to bridge the gap?
And then my next question would seem kind of strange, but I've been looking into Cinemet pills, and they're all yellow. They're all yellow. Immediate release are all pretty much yellow.
Mhm.
And I've been looking into the color that's in them, and it's yellow number 10, which is only approved for drugs and cosmetics. It's not approved for food. So it's not F, D, and C. It's only D and C. And it's in almost all the manufacturer releases, that coloring. And I just wondered if that's the problem, because it's not approved for food, and people are taking a lot of this immediate release Cinemet, and the color is actually called aluminum lake. And then I get concerned about aluminum, but no one has ever brought that up ever. And the Divi pills that they just came out with do not have coloring. They're white.
They're white. Okay, I'll be honest, I don't know the answer to that question.
But I'm going to start looking into it, because the other thing is that we had to switch manufacturers of immediate release because they're not, Mylan isn't making it anymore. Vicky took Mylan. So I asked the pharmacist about all the manufacturers of the generic Cinemet since it went off patent, And all the manufacturers produce the same pill. They have the same coloring, except there's only 2 that were scored to cut in half or cut in fourths. And when you cut the other pills in half, they kind of crumble. So that's why Divi probably came up with it, because you're not getting an accurate dosage. So when Mylan stopped making it, I switched to Dr. Reddy is the only other Cinemet tablet that's scored, so that I could cut it before I got Divi. But I'm wondering if all these people are cutting up pill, it's just not consistent. It's just
I don't know. I don't know what to make of that. I'm not someone who uses the half pills as much. I usually I'm just either 1 or 2, because I think it's annoying for patients. And like you said, it gets crushed, and then it's like half is almost like you can either just choose 1 or 2. So I don't know the answer. So if you find the answer to that, please do let us know.
And then Jimmy Choo actually took a quarter every 45 minutes from when he gets up. And then, but he's using the quarters. And he was able to drastically reduce the overall amount of Cinemet he's taking, and then he takes more. But that's not many doctors go after that. But when you look at his performance, and he was able to go off of 24 pills a day down to like 12 or 14 pills by the way he's taking it and studying it, and how he lives so he can move at the time. But I just find that very fascinating, and I think it should be shared. I don't know.
Vicki, let me just add one thing. Now, I have to preface this by saying that this information came from the Divi pharmaceutical rep, but I know it's true when I take Synthroid and other things that brand name sometimes matters. And he really drove home the fact that if it's a generic drug, there is such a wide range of accuracy that comes out of that process, and it varies by manufacturer. So maybe Divi is your answer.
And I agree with you, Christine, because when we switched, when they went off patent, when Cinemet CR went off patent and they started generic, it was much different. It was never the same. And Cinemet's been off patent for a long time, so we're getting all these generics. And all the pills look different. They're different sizes. They're a little bit different color yellows. And I'm just wondering if this yellow coloring is a problem, that no one has addressed that. And I just wondered, neurologists should really investigate the pharmaceuticals they're dispensing and what's in them. And, all this stuff came out about about red number, what was it, Vic? 3, red number 3. But I'm just wondering about yellow number 10. And having
Absolutely. I think it's a great point. I will do some research. I'm having a medical advisory board meeting tonight. So maybe that's something we can bring up and just pique interest. And Jean, I saw you try to get attention over there. Do you have a question? They're making it really hard to unmute.
All right, I think.
There you go.
Sorry. An aside to Vicky, our generic Cinemets are all white. But my question was, and I think my wife had a question. She has PD. How rigid is the scheduling for taking Cinemet? The prescription is 4 times a day, so we take it every 4 hours. But if she has a lot of movements in 2 or 3 hours, can she take them early? Can she, is it an occasion for panic if you forget and now you're an hour late? I kind of thought that maybe PRN is more appropriate, but I don't know. I know it's a pretty short half-life.
So my general rule of thumb for my patients when they ask, what if I forget? What if I'm late? My general rule of thumb is like plus or minus 1 hour is not a huge deal. And then what was the beginning part of your question? I'm sorry.
I don't remember.
Okay. It was like, well, I know you said, do you panic if it's an hour late? No, the answer is you never panic for anything for Parkinson's disease.
Okay.
You never need to panic.
All right. So it's not worth getting stressed out about it.
If you're if you're like more than halfway over the time between your next dose, you could just you use your judgment. Sometimes I'll say, okay, then just restart at that time and reset every 4 hours, and you'll just have a little bit rough of a day, and you just get back on track the next day. There's never an emergency or anything for that. No, so yeah, the PRN I don't recommend, only because once you get to a steady state, it's good to maintain that steady state, because if you drop super low and then you take another pill, it's not going to get you back up, right? You're going to play catch up for a while. So that's why the PRN is usually recommended, but an extra dose PRN is okay. Again, depending on your clinical scenario. If you are someone who is super dependent and you are 1 minute late and you get stiff and slow and freeze, then yes, you are someone who needs to take it every 4 hours. If you are someone who's not, and like sometimes you're late, sometimes you need an extra, okay, that's fine too. Everybody is different and it depends on their age, their lifestyle, ability to remember and coordinate. And so that's no right or wrong answer there.
Okay, thank you.
Mm-hmm.
Jean, can I ask you what manufacturer you have that's white? Who's the manufacturer?
If you give me a second, I'll read it.
Yeah, we get ours from Giant Eagle. And I asked the Giant Eagle pharmacist, and they don't have any.
Ours come from
Rite Aid.
And the brand name is, these are the short-acting ones, of course.
Yeah.
I'm so sorry, actually. I'm going to have to pause and step out because I'm going to have to go on to see my patient here. But is there any last minute stuff anybody needs from me?
May I just give props to Mama J, who mentioned that, she got different information from her movement disorder specialist. And as we all know, every person is different. Every movement disorder specialist has different opinions. And I really do think you have to be the biggest advocate you can be for your disease management. And if that means talking to someone else, then do that. And that's why I think Priya has been such a wonderful addition to our community.
Thank you.
Vicky,
Yes.
our pills are made by
Go
someone.
ahead, Christine.
Our pills are made by someone called True Pharma. TRUPH.
Okay, I'll write that down. I'm going to ask about that. But that's good that it's white.
They're white.
I do. I don't know how to figure it out.
Good to know. Thank you.
Is that
Any
good?
other questions? I know that Priya is gone, but if I'd like to put in a plug for our conference on May 3rd, the Living Well Conference. It's always informative, and there's a huge vendor village where you can check out different meds, different devices. And then for those of you who are sports fans, on April 22nd, we have an event at the Left Field Lounge of PNC Park. And that date, it's a Tuesday night. It was chosen deliberately because it's a few days before the Steelers draft. It's what we hoped would have been the start of the Pens playoff run, and it's the start of the baseball season. So we have experts who are going to talk about each of the teams and what should be done. And it's sad to say that the Pirates are our biggest hope right now, at least for the next month. But we're also going to have celebrities in the audience and a lot of retired Steelers and Penguins and baseball players and auction items. And if you just want to have a good night, we expect the crowd to be very raucous and challenge what these experts have to say. So all can be accessed on our website. Any other questions? Ooh, I have a new message. Hold on. Thanks, Karen. You're a sweetheart.
Who will be the featured speaker at the May Expo?
It is a woman by the name of Terry Pease, Pease. She married a man when they were older who already had Parkinson's disease. And she talks a little bit about the caregiver journey and communication. And it's almost taking off a little bit from Matthew Moore's play from last year that was so compelling. And by the way, his play is going to be turned into a movie for those of you who saw it.
Mm.
But we're going to have our expert panel of docs. Dr. Cardone, I'm hoping, will be one of them. I talked to her before you all got on. But we'll have a mixture of nurse practitioners, movement disorder specialists, physician assistants. And we're going to have Jess Neese talk about, like, she reached out to us, which I thought was great, and said, you have these medical experts up there talking about Parkinson's disease, and to a person, they will say the most important thing you can do is exercise, but it stops there. And so she's going to give a little discussion on the best exercise and how to exercise and why it's so important, and the importance of a physical therapist or speech therapist, occupational therapist, the whole bit. So I'm trying to think of what else is on the agenda, Vicki, and my brain is fried.
I just want to mention that Jimmy Chu's talk is good. I don't know. It was not recorded, so it won't be on their webpage. But he also brought up exercise in the Spark study. I know we've talked about the Spark study and how you have to get your heart rate up to 80% max at least 3 times a week. But he does 6 times a week. But he mentioned that too, that's you have to do something you enjoy. But the most important thing to him, and he's going to be on Ninja Warrior this summer too, as his last performance, is
with his daughter.
With his daughter, yeah, yep.
He already filmed it.
Oh, he did. So okay, so yeah, but I thought that, and I know that. Well, the one expo we had him as the featured speaker here, which was really great. We were the first to do it. So,
well, we talked about bringing him back this year.
Yeah.
And we decided maybe I'd love to have your opinion, if you want to raise your hand as to who would be interested in seeing him again because his disease has progressed. He's going to be on American Ninja Warrior again. His daughter could speak to, having a father with young onset PD, and there's all sorts of other topics that he's willing to talk about. But he is very, very upbeat, honest. And for those who saw him 2 years ago, it was a highlight.
The latest talk, he got into more describing about how he takes his pills and how food affects him and what diets he's tried. I mean, he got into real specifics, which was real helpful.
Right. He's also very expensive. So
Okay.
we're raising money big time to try and make sure that we can get him back quickly, because I think the two people we'd really like to have again are Ray Dorsey, who wrote the book Ending Parkinson's Disease, and they're about to come out with a new book, and I think it's like the 25 things you can do to either prevent PD and his view is all about the environmental things that cause so much of what happens in our world, not just for PD, for cancer, for many other diagnoses. So I think he would be great to have back, along with Jimmy Choi. We have a big long list, but if anyone has suggestions, I'm happy to
I
hear
do,
them.
Christine, and I'll send you something. I do have a suggestion.
Cool. Very good.
It's kind of controversial, but
I would
think it's
expect
making
nothing
real
else from you, Vicki. You're good.
But it's all about that Parkinson's is a stress condition. It's from chronic stress. It's not a dopamine condition. And but Lillian produced a book too that we could add to the book list. But if people want to hear something different, do all sides maybe if we're brave enough.
Yeah, I mean, that's the thing. We need these movement disorder specialists, and I don't want to tick them off by saying that everything they've been touting for the last 30 years of their career is wrong. But I do think we need to challenge, just like Priya, I think, is doing in a subtle way. We need to challenge the status quo and think about other things.
Right.
And if I may just add to her Vialev discussion, that it used to be called Duopa, and Duopa will still exist. And to me, it made the most sense of how best to deal with Parkinson's disease, because the gut is the big issue. Your meds don't get through. And Duopa, the initial version, there was a stoma into your stomach, and you wore this big device, and it was cumbersome and awkward, and you'd have to take it off at night and clean the tube. And our local movement disorder specialists did a negative sell on it. They would talk about it in their clinics with patients. They would say, yeah, but you have to have this big device. But in the meantime, people were able to often reduce the level of carbidopa levodopa they were taking, because they were getting the dose they needed because it wasn't trapped in the gut. So now they came out with this, it's like an insulin pump, and it's 24/7. You sleep with it. I mean, there is still some maintenance of the insulin pump, but all night long, I mean, and what people have found the most is that they sleep better. They never need to worry about when they eat and the protein. And they're less stiff. And when they wake up in the morning, they've had carbidopa levodopa. So you're not stuck in bed while you wait for your meds to kick in. So I know that it's not covered right now on Medicare, but it will be soon. And if I were diagnosed with PD tomorrow, I'd be on it. Just sharing that.
I'm on a website with users of that. It's on a Facebook page, but yeah, they say it's very good. And the Duopa pump, they specifically said you couldn't run it overnight.
Right,
And if you're of
exactly.
the philosophy that it's not a dopamine problem, then this pump, any of these pumps will be no good.
Right,
But if we are after a dopamine problem, and this avoids the gut, the only problems they're really having is skin conditions, getting it infected and finding spaces to change it because they have to change it every day, and they
right,
have to wear it all the time.
right,
But it is having better results because I think they're controlling the amount better, and you're not going through your digestive system, but it's still going in the bloodstream, so you're still delivering uh, dopamine to all your organs, not just your brain,
right.
including your
Well,
heart.
I know that they've been working with the under 63 crowd because they have commercial insurance. And all the years that Duopa was available on the market, they had, I think, 1,200 systems in play in the United States. And since they started these trials, maybe 2 months ago, they've already surpassed 1,200. They're closer to 2,000 now just in the US alone. So people, you have to be patient. Apparently, you have to give it about 3 weeks to get used to things. But we do have a young onset gentleman who in our community who tried it, and he's a different person. He was progressing very, very quickly, huge dystonia. Um, I'm not sure that he's sharing the sleeping better part because he has sleep apnea, but he's just a different person. And I would love when he's ready to get him out in front of folks and talk about his experience.
Or maybe get that Valley people to come to the expo. That would be interesting, really
They're
interesting.
they're going to be there for sure.
Okay, good. Yeah, that's great. Do you know how much he reduced his overall Cinemet that he was taking?
I do not, and he may not be at the point yet. I mean, he just started this, so he may not be at the point where he's reducing quite yet. But I mean, his depression, his affect, his whole demeanor, he's just a different person. Now, we all know that the placebo effect is very strong in Parkinson's as well. Maybe it's that, but so what? Take it any way you can get it, right?
Because you could generate your own dopamine if you think you're getting better. You can generate your own.
Exactly.
That's why the placebo effect is good. Take advantage of it. Start
Right.
generating your own dopamine. Right. Thank you, Christine. I'm sorry we're late, but these talks by the dog aren't recorded, her talks yet.
Yes.
They
She's now
are.
letting us record it, which is why we did the first one over again. So I put in the chat, but if you want to look at any of our recordings, you go to our homepage. On the top right of the homepage, there is the Facebook, Instagram, YouTube, X icon. Click on the YouTube icon, which is an arrow to the right in a square box. When you click on that, you go directly to PFWPA's YouTube channel, and you can see hundreds of videos.
Okay, great. I didn't know her talks were being recorded. Thank you so much.
Yep. And the most recent ones she did were on cognition, which were quite good. So be sure to check those out. And I think next month she's going to talk about gait.
Okay, thanks.
Yeah.
Thank you all.
Thank you.
I'm sorry we kept you so long, but I love being with you. And even though I'm hopeful for Casey to come back, I was happy to sit in. So any other questions?
Is Casey off, Christine?
She's on vacation. Yes.
Oh, okay. She's
And
not.
I'm really trying hard not to bug her.
Okay, thanks. I'll try not to bug her in. Okay. Thank you.
You.
Thank you.
Bye, everyone.
Thank you.